or at least a paper copy of a draft amendment to the bill that I sent out. If anybody doesn't, I've got some extra. What's that? It says, what's that? It says 5-1 at the top.
Yeah.
Some 45-1 at the top. It's a different.
It says the
Oh, he needs-
amended amended bill,
Yeah.
not just an amendment.
Actually, thank you.
Okay. So, kind of as a recap, I know there's a wide range of concerns, but I think some of the ones that I know I heard from the committee were related to, if the optometrists are going to be permitted to do additional things, the question is, do they have adequate training? Especially given, as I understand it, that the schools they attended may not have been able to, either didn't provide the training or didn't provide what might be viewed as adequate training, if for no other reason than they were in states that did not permit performing some of these procedures on actual humans. And so they would not have had any live practice. So that was a concern. And there were also some views that some parts of the bill, the existing bill, had a lot of detail in them, especially around glaucoma, and maybe that should be in rulemaking. But what I'd like to do is go through the changes in the draft and, see what people have in the way of comments or questions or any of that.
Question of the chair.
Certainly.
Have we provided copies of this to the guests?
I haven't, actually, if somebody could put them up maybe on the table there and people can grab them. Yep, I think, yes.
I just have a comment on the training piece
Yeah,
before we dig into the meat.
sure.
I thought a lot about this, and it's sort of the chicken and the egg story of no school's going to engage in the training if the opportunity isn't there to practice it, because they're not likely to garner
Right.
students. And so if the board doesn't approve it, it's sort of the chicken and the egg thing.
I think there is an answer to that, and we'll get to it.
Good. I'm anxious to hear it.
It is an issue. But as more states are permitting this, at least some of these, then I would expect that would change. And if that causes a slow start to optometrists being able to do that here, then that's what it is. But that's what will happen. So anyway, the first change is on bottom of page 4, mostly on page 5. And let me do that too. And on this thing, it's not red, but I made it bold and a larger font, so hopefully it's visible. And all this does is there's, this is the section on,
It's actually the last word on page 4. Right?
yeah,
Right.
the very bottom.
Okay, that really is the very bottom.
Yeah. And it's related to an optometrist licensed to practice optometry prior to 93, and some training they would have to do. And that first sentence and last are left in there. One is that they have to take the training, and the last is the board shall adopt rules under RSA 541A to carry out the provisions and ensure safety of the public. But it's taking some of the details out in the center section there. Representative
Yeah.
Manchaputi, and then I'll get.
Thank you, Mr. Chair. I do appreciate the fact that we are giving provision or the word grandfather in. So if somebody graduated from school January 1993, and these techniques were not even in
No,
existence.
this doesn't address that at all. I mean, this is language that was in the bill around the treatment of glaucoma that they're permitted to do now. When that was, my understanding is when that was added, there was an issue that there were optometrists, sorry, who had not had the training for that. And this would required them to get that training before they could do that. And it's being left in. I don't know that there's anybody else that's going to get licensed newly who had their training or their initial license, prior to 93. But in case there is, that's left in here. But the details on, I mean, this gives rulemaking authority to the board to come up with the details of that training. And generally, when we do that, we limit the amount of that detail that's in statute.
That's what I was going to point to,
Yes.
is that the rulemaking is still left to the optometry board, which has functioned as a board to govern their profession. So that rulemaking authority is still at that, so that they have the ability to govern it that way, make the rule, and not the legislators to say what profession can do what professional procedure.
Correct. Although the legislature will review whatever the rules are through the JLCAR process, but the part of 541A. And Representative Simon, you had a question or? No, okay. And Representative Grota.
Thank you. So I just want to make sure that we just check this with, was this also recommended by OPLC that we take this out?
Who's here from OPLC? Anyone? All right. Oh, yeah, he may be, actually, it's Doug Osterhout is supposed to be here. We
Yeah,
can,
I can ask. I'll just
I
make myself.
have the amendment suggested by OPLC.
that's included in here and we'll get to
Correct.
that.
Yeah. So I don't think it has anything to do.
No, it's
with
a
this.
different section. Okay. But yeah, when he comes, if you want to ask that, that's fine. Yep, sure.
Thank you, Mr. Chair.
Representative Brown. Yeah.
So, yes, thank you. What you are deleting is what is currently in the law.
Correct.
And just to make that the decision of the board and not to have it in law. That's the point, right?
Right. And to have it go through rulemaking, which is, there's public comment
Yep.
and all that. And the legislature reviews it, which is part of rulemaking.
Okay, and that's because it was thought to be too much in the weeds for the law.
Right. And there may have been reasons when this was new to do that, but that was 93's been a while and there probably aren't. Representative Grota?
So last year, when we went through all these changes in OPLC, one of the things that we did do was remove a lot of these dangling rules in statute and put them in rulemaking. So that way, if the rules needed to change, they could change. And I would imagine that's also in line with that.
Right. It can be updated as things change more easily than having to go through this process. Representative Mangiaputi.
Thank you. So that clarified in terms of giving the rulemaking to the professional board and process for licensing to OPLC. So that delineated and increased the transparency of the process. Correct. Thank you.
Okay. Representative Brown.
Thank you. So for me to be clear, as what it used to say, what it says in the law now is if you're prior to January 1st, 93, you had to have a postgraduate course of study, but after that, it wasn't in the law. So am I assuming that a postgraduate course of study after 93 was the norm? I want to make sure we aren't deleting something that
Yes.
changes.
We're getting head nods over there. And that was my understanding that date was there because the schools of optometry added it
Okay, thank you.
after that point. I'm going to go through this to address the changes in this draft. If there are questions about other things in here, just, let us know. Representative Schmidt.
Thank you, Mr. Chairman. So I hope that this process we're engaged in this morning is going to be an interactive one with the experts in optometry and ophthalmology that we have with us this morning, so that we don't talk over their heads or disregard. So I hope that they are going to be allowed to interact with us as we do this, because we know what the rulemaking process is. Those of us who are on the Joint Legislative Committee on Administrative Rules that we call JELCAR, Mr. Demers, Mr. Curtis, wherever you are over there. The thing is, we know what we're talking about, but to the degree they don't understand, I don't want to talk over the top of their head.
Sure. And if members of the committee, subcommittee, I should say,
Right.
have questions, that certainly they can
And
be
so,
asked. But the rulemaking process is, which I think a fair number of people here are familiar with, but if you're not, the board would draft proposed rules. They have to go out for public comment. There's a period of public comment. They have to take those into account. And there's also a public hearing. And once they settle on the rules from that, then there's a joint committee of the House and the Senate that reviews those rules and can ask for changes, and then there's a whole process there. And actually, while we're still on this section, and Mr. Osterhout arrived, there was a question, so if you could come up, please. Introduce yourself, and then Representative Grota. Yeah, thank you. And that's the draft that I put together, with consulting with a bunch of people. And we're going through the changes in that draft, and then if people have other questions, and that's Representative Grota.
Mr. Osterhout, at the bottom of page 4, it's section 8 on optometry, paragraph 2. The very last word, every, continues to the next page. And it talks about optometrists that are licensed before January 1st, 1993, and those requirements for that. And we are striking that out and making sure that that is part of the rules for under RSA 541. So is that something that you would not object to from an office standpoint?
Good morning, Douglas Osterhout, OPLC. I realized I never actually introduced myself. The office wouldn't take a position on that. We wouldn't have a problem with that.
Okay, thank you.
Okay. Representative Mangiaputi.
Thank you, Mr. Chair. Another question in terms of the same section, the rulemaking and the licensing are two processes that OPLC is in charge of one, and the other one is for rulemaking for the board. Is that this is clear with the language, the change in the language? Would OPLC see that as a?
I think it's clear. I'm just looking at it now. I think it's clear. Especially in read in context of the rest of the Practice Act and RSA 310. I don't think there'd be any confusion from our perspective.
Okay, thank you.
Okay. I'd like to go on to the next change in this draft. I'd like to go through the change of this draft, and then if there's other questions, I'd like to address them then, if possible. So now we're at page 7, near the top of page 7. This is really the most substantive change. And, as I mentioned before, there were concerns about, optometrists not having adequate training due to the circumstances to perform some of these procedures. And this section is examinations and licenses, authorization to perform ophthalmic procedures. And it says, unless otherwise specified in this chapter, the board will have the authority to determine what constitutes the practice of optometry, and that by persons licensed in that chapter. And that was in the original bill, but it goes consistent with curriculum of nationally accredited schools and colleges of optometry. And the Board of Optometry, there's an editing thing there, and the Board of Optometry shall adopt rules under RSA 541A establishing credentialing certification which shall be fulfilled before a person may be certified to perform ophthalmic procedures for the practice of optometry. And then it lists a number of things that have to be done as part of that rulemaking. And the first is identification and categorization of ophthalmic procedures for the practice of optometry. I mean, the thing is, there are likely to be optometrists that aren't interested in doing all of the new procedures. Maybe they wouldn't do any of them, maybe they do some. And requiring all optometrists to have the training in everything, if they're not going to do it, I don't think makes sense. And so this is to have them create categories of them, establish an application process for certification to perform them. And one that met some key concerns is establishment of minimum education training and live experience requirements for certification to perform such procedures. And that would be done through rulemaking, which, anybody has input and can comment on. It didn't seem to make sense to put specific numbers or hours or whatever in here. I don't think we have the expertise for that. Exactly. But it does require that they have training for the particular classes of procedures they're going to do, including live training. Representative Mangiaputi.
Thank you, Mr. Chair. I think your chain of thought is very much in line to our discussions we had earlier with the public hearing. So I have questions to two folks. One is ophthalmology representative and optometrist. It's the same question. Are all ophthalmologists performing all of the procedures or their specialization under ophthalmology license? Similarly, optometrists, not all optometrists are performing every single procedure. Is their specialization available if I am an optometrist and I want to just do the latest, I was trained to do just the laser procedure, then it's upon me to get certification. Similarly, with the ophthalmology, I know with the medical field, you have the specialization track where you can do an additional fellowship and, and so you can super specialize, but this will help. So is that in existence right now?
So I think Dr. Riccardi, if you could answer that. And I'm sure we'll get back to you, Doug, but. Well,
Good morning. Thank you. My name is Kim Liccardi. I'm an ophthalmologist practicing in Manchester, and I'm the current president of the New Hampshire Society of Eye Physicians and Surgeons. To answer your question, Representative, all ophthalmologists, as we complete our residency program, we do perform basically we experience every procedure as residents, and we are required to perform them as an assistant, as an observer, and as a primary surgeon. Technically, we can do all of the procedures when we graduate residency. The majority of us may choose to do a fellowship to further subspecialize. And with how specific and detailed medicine in general and the eye have become, for example, I learned retinal procedures as a resident. Most retina specialists do an additional 2-year fellowship. So I generally do not perform any retinal procedures. I refer those to my colleagues who have done a retina fellowship. And we have several different 1 to 2 year fellowships that many people pursue.
okay, thank you. And follow up to that, is that just the practice of ophthalmologists? if they're going to specialize in some area, they're going to do a fellowship and get further training? Or is that required either in statute or rules?
It's not required,
Okay.
but you would have difficulty, say, obtaining hospital privileges to perform certain surgeries had you not completed a fellowship and demonstrated, a case log with experience.
Okay, thank you. And, oh, you have a follow-up, sorry.
So hospital privileges in inpatient surgery or hospital surgery is one. And many of these procedures now, the advancement of technology has provided opportunity for the ophthalmologist to do outpatient in your office kind of thing. Does that require board certification or authorization?
So once you move a procedure into your office, the oversight of, say, a hospital credentialing committee is gone. A lot of us operate at outpatient surgery centers, which are not hospital affiliated. However, they do have similar credentialing processes.
Who does the credentialing then? The Board of Ophthalmology.
Of the Board of Ophthalmology,
Who credentials the outpatient currently?
other than we are board certified, we're licensed in the state. The oversight is the Board of Medicine.
Representative Schmidt, yeah.
I think the question that we would need clarification on is, we understand the hospital, you ain't going to be able to do that if there unless you've been sufficiently trained and credentialed and so forth. These centers that you were referring to, the question is, who credentials them? But more specifically, in my case, is you reference the fact that some practitioners may be doing this in their office. If we're going to permit optometrists to do this, then we have to have some kind of oversight that we know that the person has had the necessary training and that they have the necessary skill and experience so that it can be done safely on the patients of New Hampshire. That's my concern, and I'm sure it is of my colleagues as well.
I agree.
Who is checking the procedure if it's done in the office of the ophthalmologist, and it would have to be similarly overseen, credentialed, and safe in the case of an optometrist doing the procedure theoretically, right?
Yep.
I mean, if we go there.
Yes. And that is one of our issues with the bill is there.
So can you speak to how it's checked on if an ophthalmologist is doing it at his or her office, who is controlling for quality and safety in those instances? For ophthalmology, then we're going to have to know that the optometrist is going to be similarly capable. I don't think some of these are clearly surgical things that I don't think very many optometrists are going to want to get to that level of thing. We're talking about a limited expansion of optometry, not the full board, right? So
Yeah.
I need to have more buy-in from you guys with regard to how this is going to be, how it's done at the moment for ophthalmologists and how it's going to be done for optometrists.
Well, just a moment. Can I jump in here?
Representative Grody, yeah.
They're not going to answer optometrist questions. We're asking you, how do ophthalmologists, who is the one that gives the ophthalmologist credentials for practicing in their office or practicing outside in an outpatient clinic? That's the question. From your field, how do you do it?
So we have all completed a residency program in ophthalmology with minimum training requirements. That program has been certified by the ACGME, which is the American College of Graduate Medical Education. This provides reassurance that we meet a minimum competency, demonstrating that we're competent on live patients. And then once we have completed that, the Board of Medicine, as they're issuing our license, is reassured that we have demonstrated a minimal competency in the procedures within our field.
Follow up.
Oh, yeah.
So the Board of Medicine license, the licenses you get from the Board of Medicine allows you to practice in your office and on an outpatient basis. at
Yes.
Outpatient clinics. Is that right?
Correct.
And then in addition to that, if you want to practice in a hospital, you have to meet their criteria and and that's where hospital privilege.
It's an additional credentialing
Okay.
process.
That answers our question. Thank you.
All right, thank you, thank you. Oh, wait, hang on, another question. Representative Brown, sorry.
Thank you. Sorry, I always need clarification, apparently. So that would be the case probably for any certification across any industry. You're certified to this by the licensing agency. You can do it wherever you want unless somewhere you go has stricter requirements.
Yes.
Does that make sense? That's what we're all saying, right? Thank you.
All right, one more, Representative Gould.
And just another brief clarification. So what you're saying is, in terms of specialties, specializing in any of those areas you've been minimally trained in, there is no credentialing that happens beyond the normal licensing for your occupation that applies to the credentialing if you're working in your office or in one of these centers that's outside the hospital realm. Is that correct? Did I understand that right?
Correct. There's certain procedures that you might be required to carry additional malpractice insurance for. So
Anyone else? Okay, thank you. Okay, I'd like
I have the same question for the
Yeah,
optometrist, if they can answer.
we're working on it here. I'd probably, Dr. Sawyer, would be best. And, what I'd like you to do first is, actually, you almost have to eat it.
Got it.
Thank you. If you could go over this section, the changes to this section, and I don't know if there's a copy.
I believe I'm from.
Yeah, there you go.
Oh, no, I've got that one. Yeah. Yes, I believe I have it here in front of me.
Okay.
So again, my name is Dr. Angelique Sawyer. I am an optometrist and practice owner in North Conway and Berlin, New Hampshire. I am a past president of the New Hampshire Association of Optometry. So in answer to your question first, all optometrists coming out of school at this time have the training and the education. What they may not all have coming out of school is that live patient experience. This amendment is specifically requiring that there will be a live requirement necessary. Some of the students coming out of school will have the training, but if they do not plan to go on to do these procedures, they might not seek out getting that live patient experience. If they're in a state that has the authority to do that, they will likely have that experience as part of their education. And as more states have that, it will become inherent that more are graduating with it, whether they're seeking it out or not. Well, we're still in a period where there are a number of schools that are in states where that is not something they can get at their school on a regular basis. It is incumbent on them to seek that out. During the fourth year of the optometry training program is entirely in clinical practice, and students have the opportunity to choose where they do that clinical practice. So if somebody is planning to go to a state or they're wanting to, in their future, perform these procedures, they can seek out rotations in the states where they will be able to get that live experience. Within the 4 years of optometry school, which includes that year of clinical rotations, we have learned the basics. What may be missing is that live experience. The additional residency is for optometry is akin to the fellowship for an ophthalmologist. If they want to then go on and specialize and just do retina, they may do an additional fellowship. In optometry, because we know from day one that we are specializing in the eye, All 4 years of our training are focused on the eye and how we are going to be treating all of these conditions, how these systemic conditions relate to the eye. In ophthalmology and medicine, your 4 years of medical school, you don't know that you're going to be an ophthalmologist. So only when you begin your residency are you then now becoming an ophthalmologist and beginning your more specialized training in that residency process. So their residency is very different to what an optometric residency is. Our optometric residency is more akin to their fellowship, where we have all that basic training within the optometric education, and you could then go on to specialize if you wanted to be a pediatric ophthalmologist, if you wanted to do specialty contact lenses, if you wanted to do vision therapy for people who have low vision. Those are the more specialized optometric residencies. So I hope answers your question there as far as the type of training, and where some will come out of school having this training, may not have the live experience, and may not pursue that if that's not something that they're planning to do in their practice.
And one thing I'd like to add, get back, is I hadn't covered is section 2 on page 7, starting at line 23. It's no optometrist shall practice under this section unless the optometrist has submitted to the Board of Optometry evidence of satisfactory completion of all requirements for specific procedures, and the board has certified the optometrist is qualified. So if they haven't completed the training requirements in the categories of ophthalmic procedures they want to do, then they're not permitted to do them. Representative Manchaputi.
Thank you, Mr. Chair. So is there a minimum hours required by the optometry specialization fellowship, or whatever you call that residency, or for specialty, especially in operative, the newer technologies that's available, laser or cataract?
If I can just add something, and then, so setting that is given to them with rulemaking. However, what I answer the question, but also address, I know there's a accrediting association for the schools, and which the chapter mentions, and so do they have such requirements?
Yes. So the schools are all accredited by the ACOE. That is our accrediting body for all the schools and colleges of optometry. At this point, and this is why we didn't have concrete answers to be able to give last week, is that accrediting body does not have a minimum number of procedures nationwide, because there are so many schools that are not able to do this. So that is why in this amendment and through rulemaking, there is a live requirement, and there is a minimum number of procedures that will need to be done for somebody to come to New Hampshire. With time, that will become the norm across the country in all of the schools, as they have the ability to meet those minimums. But at this time, because there is not that ability, there is not the live experience minimum by the ACOE. On average, the optometry schools, we spend about 2,500 hours in classroom and lab training, and about 2,500 hours in clinic.
Follow-up?
Thank you, Mr. Chair. Thank you for indulging in the time. So from my recollection, there are 24 schools of optometry in this country, and the two closest to our state, we don't have any in our state.
Correct.
Are they doing these trainings? Or, if you're able to draw from the neighboring states close to us, are they doing these trainings? Are these available for the optometrists?
The two schools in Massachusetts are not able to perform live experiences on patients because Massachusetts does not have the ability. However, students from those schools can do their clinical rotations in states that have that ability to get that live experience.
Follow-up?
Which are those states close by, or?
The closest at this point are Virginia and Indiana.
And I think that goes to some of them, maybe Representative Gould, or if I may be remembering correctly about the chicken and egg thing. I mean, this may grow slowly because of those kind of limitations, but at least it allows that to proceed. Representative Grota.
So if let's assume that the Board of Optometry is set up, Okay, and it's doing the rulemaking as it should. So then, would they be then the accrediting body for optometrists in New Hampshire?
So the optometrists in graduating would still need to graduate from an accredited school.
Yep.
They still pass their licensing exams. Particularly if somebody were to then go on and want to do these procedures, then they need to meet the minimum requirements that have been laid out by the board. And the board is aware of this amendment. They're aware of what will be required to be done in rulemaking. There are some draft languages that are already being put together as to what that's going to look like, to make sure that that is robust and that they're prepared to do that safely. And yes, slowly. This is going to take a long time for it to go through rulemaking. It's going to take a long time for people to get these experiences. I don't envision any optometrist in the state is going to be doing this for at least a year before anybody's actually able to be doing any of these things in practice. The board is, adamant that they are doing this slowly and safely and correctly.
I think I had a follow up, but I lost it, so I'll come back to it if I
Representative
remember.
Brown.
Thank you, Mr. Chair. So this might be a question for you or Attorney Osterhout or anyone that wants to answer it, I suppose. If I'm reading this correctly, it's saying that optometrists will make decisions for their practice about ophthalmologist procedures. Would that be similar
It's-
to, would that be similar to an electrician making a decision for a plumber?
No. Ophthalmic procedures means relating to the eye. It is not specifically an ophthalmologist procedure or an optometric procedure. So that term in that line where you say to perform ophthalmic procedures simply means relating to the eye.
Okay.
Nothing in this statute or anywhere within the bill impacts how ophthalmology practices. They're entirely within the Board of Medicine.
Okay, and follow up or another question?
Yeah, first I'm going to
Yeah,
point
go
out that if you look at under section 6, it starts on page 2, but a lot of it's on the following on page 3 and then 4. It actually provides some limitations on what the optometrists can do, and there's quite a few things that they're not permitted to do. And since that's in statute, the rulemaking by the Board of Optometry could not permit them to do it.
Yeah, and I have more questions on that after we're through this section.
Okay.
So
Yeah, I know.
I do have a follow-up.
Let's
one
follow
more.
up and then Representative Gould. Yep.
As these are then ophthalmic and not ophthalmologic procedures, the requirements for live experience don't have to match those, obviously. So that would be, the board will be setting live experience requirements for non-ophthalmologic procedures. Is that
Yes,
correct?
for the optometrist to perform these procedures would be set by the board. However, their intention at this point is to have it match the minimums of what is required by ophthalmologists coming out of residency, the ACGME, which is five of each of the lasers, and 5, 5, and 4 are the number of procedures for the lasers that are required minimums for ophthalmology coming out of residency. And so the Board of Optometry plans to mirror that in rulemaking.
Thank you.
Okay, Representative Gould.
Thank you, Mr. Chair, and thank you for taking my question. It's a pretty simple one. Regarding the terminology live experience requirements, I just wanted to, you used that term, so I'm assuming that is a common term in your field?
Yes.
Okay.
Yes.
And then the next line down on line 19 on page 7, protocols for proctoring.
Yes.
Can you just explain to me what proctoring is?
So that would be for those who have been out of practice to get that live experience. And so that would be performing procedures under somebody who is trained in performing those procedures already, be it an optometrist, an ophthalmologist, be it in New Hampshire at a school in a state that those procedures are already being performed.
Thank you.
Thank you.
Representative Grota, did you have a question?
Thank you, Mr. Chair. I just have a question. So do optometrists only practice in their office?
No, optometrists can practice elsewhere. Some optometrists do have hospital privileges and take emergency call for hospitals. It's rare. The majority do not. The majority of care is provided in the office. I don't know of any that have any privileges at ambulatory surgical centers because we aren't doing surgical procedures. Even the things that we're looking for here, while there's nothing that would prevent them from being able to do it in a surgical center, if that's where the laser was located and that's where they wanted to have it done and they wanted to pursue that pathway of credentialing, what we're aiming for here, we largely envisions optometrists doing in their office. These are in-office procedures.
Okay, thank you.
Thank you.
And Representative Mangiaputi, did you have a question?
Thank you, Mr. Chair. Just basic confusion that keeps coming up. Board of Optometry exists, and it's not a new board that's going to be formed. It exists independently of the medical board, which is ophthalmology is part of.
Yes, exactly. The Board of Optometry has been around for over 100 years. It is independent. It has never been under the Board of Medicine. The only thing changing from here is one, there is a name change. It has been referred to as the Board of Registration on Optometry rather than just the Board of Optometry. So SB 440 does to name it analogous to all the other professional boards. And what we're talking about here is that rulemaking authority and moving more into their ability to control through rulemaking rather than having it spelled out specifically in statute.
Follow up, Mr. Chair.
Follow up?
How often does the Board of Optometry meet?
I believe it's every 6 weeks. Every 6 weeks.
Oh, which I haven't seen. I don't know if I have time. I will at some point. Yep. What I'd like to do is the next section. It's very much related to this. If you look at the very bottom of page 7 and it goes on to page 8, it's an addition that says, and this is in the disciplinary action section of the statute. It adds that performing authorized ophthalmic procedures without certification based upon the requirements outlined in 327:6D, which is the part we just went through, shall be grounds for suspension or revocation of an optometry license and or certification to perform authorized ophthalmic procedures. So just to make it clear that they're not to perform procedures that they haven't been, certified by the requirements of the board, and that if they do, they can be disciplined for it. Okay. Let's see. Anybody in the Representative Mangiaputi?
Thank you. So many questions popping up. So in terms of optometrists, you also have to carry a liability, malpractice, liability, all those insurances.
Yes.
Does that change with the specialization?
If you are doing advanced procedures, there's additional coverage that you need to carry. Your malpractice or liability provider needs to be aware. They specifically ask you when you're renewing your policy, are you in a state where this is permitted? Are you performing these procedures?
Fine.
Oh, yep.
So when you and the optometrist and an ophthalmologist work together hand in hand, are there any time when the optometrist is doing the advanced procedure that liability is transferred to the ophthalmologist if you're on the team?
No.
Okay. Are there any other questions at this point for Dr. Sawyer?
Sawyer, thank you.
Well, Mr. Chairman, we're seeing hands in the audience. Excuse me. I'm allowed to participate fully here. I don't have a vote, but I'm allowed to participate fully. When I see hands being raised or heads shaking out there, I want to find out what they are referencing. This is not We have our role to play here, but they have their role. And when I see hands and they're not responded to, I'm not satisfied with that procedure. Excuse me, but when they're raising their hands, I want to have them be recognized so we can address the issues that they are raising. Thank you.
All right. We'll get to that in a moment. You have another question
I have,
for?
I do have a question that I need for clarification from myself before we get off of this section. So during the hearing, if I recall, I heard that there's 220, and correct me, anyone, if I'm wrong, approximately 220 codes for ophthalmologic procedures. The optometrist asked if they could do, that they would like to do 44 of those. So in this amendment, do you see that you could be doing those 44 procedures?
The way that the amendment is, it could be up to those 44. The board in rulemaking has the opportunity and at this point the intention to further narrow that down. As part 1 indicates, the identification and categorization of procedures, they would spell out what those procedures are. I do not believe their intention is to include all 44 of those procedures within the rulemaking.
And follow up, sir?
Follow up.
Thank you for entertaining me here. And those 44, you would say are ophthalmic procedures?
Yes.
Okay. If anyone disagrees with that, or if I can clarify any more, don't take that personally.
Not a problem.
Let the brain know here. I'd appreciate that. Okay, thank you.
Okay. Before we move on to anything else, anybody else have any further questions at this point for Dr. Sawyer? Okay, thank you.
Thank you very much.
And there were some questions from that side of the room. If one person could come up and comment. You need to turn the mic on. And,
I do. I apologize.
that's fine.
Thank you.
Yep.
I'm not that loud. So thank you. I will try to be quick. Didn't get a chance
if
to
you
look
can-
at this
if-
amendment beforehand.
You can introduce yourself first,
Yeah,
please.
I'm Catherine Morando. I'm an ophthalmologist here in town at Concord Eye Center, and I'm a glaucoma specialist. I did my training at Mass Eye and Ear. I'm 2 years out of practice, so hopefully I can well remember training and speak maybe to those aspects of what's being addressed in this bill. So I think one thing that's important is that, and it's quite novel, is that there's no model in any other state for minimums or criteria in the training. 2 of the 24 states that allow, have residencies that allow hands-on training. What we heard at the hearing was that there is no minimum right now for the number of patients. And the way in ophthalmology we determine competency is more than just minimums, because you could have a minimum number of procedures and still not be competent with them. The ACGME actively works with these programs and residencies to ensure that the residents are meeting criteria, have active meetings, make sure that the professors training are qualified themselves and actively evaluating before they would graduate someone. We don't have an optometric school in New Hampshire, so it's not that this bill would allow that training to begin here. And we have it's very not like we have no other state to even look to for how this is being done currently. I know I'm not an optometrist. I'm trying to learn as quickly as I can about the depth and breadth of their training, but I don't presume to know exactly what they go through. But I can say that I don't see another state to even look to understand how we would implement this here. And I also think that in terms of patient safety, which is the reason that I canceled my clinic this morning, I don't understand the outcomes reporting and way to measure safety, because we know we brought someone to the hearing who was blinded by one of these lasers, yet there were 0 reported outcomes. So I think we don't even have a good system in another state to look to where they are having minimum criteria, where they are reporting safety. And that minimums alone are not enough to determine competency, at least in the way we do it in the medical side of things. And then we also had a letter for speaking to the insurance coverage. OMIC, the major supplier or major provider of malpractice insurance, had a letter that they did not support extending these surgical coverage to optometrists. Most ophthalmologists are even covered under OMIC, so I don't know how if there would try to be some type of merger together of ophthalmology and optometry in training, how we would even be able to help supervise. I'm not seeing a pathway forward in this amendment, and it was just presented moments ago, but I've tried to look as much as I can into the training. I just don't see understand a safe way that we're considering how we're considering patient safety with this.
Okay, thank you. I'm gonna ask Dr. Sawyer to give her perspective, but are there any questions before that? Representative Manchaputi.
Thank you, Mr. Chair. Thank you for taking my question, and thank you for being here. I know it's difficult, but I understand that the schools in optometry has just started this, or 10 years ago, or in the 2 schools that are training in this specialty has only started 10 years ago, 15 years, when the laser started with ophthalmology too. So that was my point in terms of it didn't exist. So the malpractice insurance for ophthalmology, the company that does that, is not even aware of the fact that this could be something coming up for optometry. So, the optometry, will they cover or not cover? That is, if they're not able to get the malpractice coverage, how can they even practice? Because that is the critical thing, right? So there is one, at least from my point of view, that's there is a check and balance, I believe, from the liabilities. Don't you agree?
Well, there's more than just OMIC, which is the insurance provider that I was mentioning. So I'm sure there would be potentially ways around that. And then OMIC did submit a letter that was included in the packet. I'm so sorry, I don't know offhand. But OMIC did submit a letter with the knowledge of this this bill being put forward. So it is with the newest information that was provided to them. And I think that even if this is a newer concept being put forward to have optometrists trying to do surgeries, we should have a framework in place for safety and training before we are out practicing and certifying providers to do surgery on patients, which is currently happening, but in other states, but there's no competency criteria to attain that status. So it seems like the cart is far ahead of the horse.
Actually, Representative Grota.
Thank you. So I'm not sure you understand, because the cart is not in front of the horse. Okay? There's no cart even. There's no horse. All we have is what we're saying is that the optometrists will form their criteria to proceed to do these procedures. They may be different than the way you perform them. But when you look at all the things that you do, let's say, of what sliver of the pie are these procedures that they want to do? What sliver of the pie?
I guess I do about 20 every 2 weeks. I'm
Not
I'm
you
not
per
sure
se,
exactly
but
how-
I'm talking about, of all the things that ophthalmologists do,
Yes.
what percentage are these procedures? And what is the percentage of risk in these procedures? Are we asking them, like, for example, I'm using this as a hypothetical example. if I want to take a splinter out of my finger, right? I'm going to go to my primary care physician and they can take the splinter out. They're not going to send me to a surgeon, right? So if I go to an optometrist or my optometrist and I need one of these procedures done, if they are accredited by their board to do so, because they have done so many of these procedures, and it's not up to, we do not look at what other states do. We look at what is right for our state. That's what we decide. We base it on what we want. We don't look at what other states do, okay? And one of the requirements that became very apparent in the hearing is that live clinical experience was required. And we went to the, excuse me, the ACGME, and we use those, right? So you can't say that we have no criteria or that the cart is before the horse, because we have set up the criteria. You may not agree with it. That may be the issue. But don't say that we haven't said anything or that we haven't done that, because we are doing that. That's this process. Does this make sense to you now?
I apologize. I think this is new to this amendment, which I'm just seeing now is this introduction of these, just introducing the ideas of minimums. So I completely appreciate that. I truly am here just for patient safety. I don't in any way think that, I'm sure there are plenty of optometrists that are much smarter than I am. It's really just a pathway of providing safe care. And so I'm trying to make sure I understand that. And that's what we're discussing today. But
And I apologize if I sound, first of all, I have allergies, so I don't normally sound like this. But also, one of the reasons why we are on this committee is that we care about public safety as well. We get bill after bill after bill about licensing. At the same time, we are also sympathetic to hurdles that could be put in the path of others who are competent to do it, but others are concerned and won't let them. So we're going to test that hurdle, and that's our job. That's what we do. At the same time, we weigh that, and we weigh public safety. So I just want you to understand that, and I appreciate that you're here for public safety, but we're here for that too. Does that make sense?
makes perfect sense, and I appreciate it. And so I think then I am complete agreement that we should be looking at the competency criteria and how to go about ensuring that. And I just don't, I'm not sure what the pathway is to that. I don't see a plan that makes sense yet. So I'm glad that that's what's we're trying to understand. And you had said and then safety. I guess that's where I have maybe the most understanding, and that was my testimony previously, but these are not like removing a splinter. You can be blinded and it's irreversible.
Just a moment. One thing I will kind of tried to explain it before, but in the section where it's talking about, determining what the procedures are, what the process is, what the education, training, and live requirements are, and all of that, what it means when it says that's going to be done through 541A rulemaking is that it's not that the optometrists on their own are going to cook up whatever they want and go forth and do whatever they want. That is open to public comment and review, including by ophthalmologists and everybody else in the state or country, I guess. So part of the process is that I suspect there will be a lot of scrutiny of whatever proposed rules they come up with, and then that's going to be reviewed by the legislature as well. And so we're not telling them to go out and do whatever you want. That's not what this process is. Reverend Simon?
Thank you, Mr. Chair. Yeah, just for clarification purposes, because it is a very dynamic situation, it's changing constantly. So I appreciate the position that you're in with new information coming at you. all of the time. But in agreement with you, just real briefly, what you're looking at in that amendment is the skeleton. Essentially, we set the skeleton, and then through rulemaking, they'll fill in all of the details of what that pertains to. I did ask at the last meeting for the optometrist board to give me a sense, an idea of what that rulemaking process might look like, what kind of requirements that they're putting in place. I've received that, which I was appreciative of. It's right now, I mean, it's subject to change, but it's about 3 pages long, and it does take into consideration the things that you're talking about. So beyond minimum standards, which it does have minimum standards in it, it does also have a preceptorship, which maybe somebody will have the ability to talk to, so that somebody with experience is going to be overseeing the training and putting their stamp of approval that they are actually competent in doing the procedure. Not that they've just done 5, but they can actually do it well with public safety in mind. And there is also a reporting requirement for procedures that are done back to the board so that we can keep an eye on that sort of thing. So once again, that's not what we'll handle here in this particular place. Unfortunately, the process will be longer if this bill goes forward, because we will be pushing it over to rulemaking. And then all of those components will come up, and you'll have an opportunity at that point to speak any concerns you might have with the very specific rules that are coming up in those categories. So just so you know, it's not make or break it here. So that was all I wanted to say. Thank you.
That's all interesting information. So we'll have to review that.
Representative Schmidt, I'll get back to you.
Thank you, Mr. Chairman. So the chair stated earlier, toward the beginning, one of the things that we always have to keep in mind is we are not opening the entire museum here. We are considering expanding what optometrists can do in certain specific areas, not the entirety of what ophthalmologists do, but certain specific things. And that's all we're talking about. And the chair wisely alluded to that earlier on. So that's what we're trying to do is, what I'm trying to see is to get at the things that the optometrists are asking to do, to see which of those things you say absolutely not, or possibly that this could be a workable area in which optometrists could be sufficiently trained and credentialed and so forth, and in which it would improve access in the entirety of New Hampshire. And that is, as Representative Grota said earlier, that's our concern. What can we do for the benefit of the people and the state of New Hampshire that would also benefit the optometrists in expanding their practice, but not opening the entire museum, as I said. So, and the chair alluded to that, and we have to keep that in mind. We're not talking about everything. And Representative Simon said we are creating he called it a skeleton, but the amendment, if we adopt it, will permit the rule writers, with the involvement of stakeholders and practitioners, to develop the necessary rules in that one limited area or small areas that we are specifically talking about. That's all. We're not trying to get into the whole ocean here, just one little cup of it.
Representative Grota.
Thank you.
Sorry, Representative Mantrapudi.
Thank you, Mr. Chair. Thank you for the eye contact, so I knew it was you're referring to me.
Yeah.
One more in terms of your concern. I understand we don't want to change upset the apple cart to say, but we can't be status quo either. One of the big reasons for me as a legislator, this is important is the fact that we have workforce shortage, we have access shortage, and we don't have medical school, public medical school, dental school, optometry, or any of those in our state. How do we attract new workforce as we age? As the state ages, we need more workforce. And how do we attract? There might be this special caveat to attract more, well-trained folks to come in. rather than putting obstacles. So I'm looking at this as, do I want to age in this state, or do I have to move out to be able to afford anything? So that's a critical thing. So that is also another side to it, which enables newer coming out graduated with not a burden of debt that they can't do anything, have to go to a better paying state. So those are all the things that come into play.
Just really quickly,
Yeah.
Representative Mangiahuti, I hope you want to stay in New Hampshire. It's beautiful. And I think everyone here loves it. In the packet on page 19, we had a diagram of the number of optometrists that increased by almost 46% from 2013 to 2023, whereas the population increased by 5.6%. So it seems like there are a lot of optometrists coming to the state. I don't think we have any access data for the lasers that I think, and when we were mentioning the small piece of the pie, I think, as active amendments are coming through, my inclination or understanding is that what is wanted are 3 lasers: the YAG, PI, SLT, and YAG cap. And those are elective lasers. They're not emergencies, and access to those is they're just not emergencies. So it's not needing to be seen within a week. I don't have any data of access issues with those 3 specific lasers that are being addressed in this bill. So I'm a little unclear on how this bill solves issues with access. It would be interesting if there was data showing otherwise.
Okay, thank you. I don't know. I'd like if either Dr. Sawyer or Donahue want to comment on any of that.
Thank you.
Thank you. Yeah.
Thank you. A couple of things that I will just respond to. First, OMIC is from their website. It was started by ophthalmologists. They credential and I'm sorry, not credential, but they provide liability coverage for ophthalmologists. So from their website, our mission is to serve the needs of the members of the American Academy of Ophthalmology. So I'm not surprised that they wouldn't support or cover an optometrist. But in all of the states that optometrists are performing these, they have no problems in securing malpractice insurance. It was brought up that there are no states to model after. There are states to model after that do require live requirements. Kentucky requires live practice, live cases before practicing independently. Most recently, South Dakota passed this just this year, and they also have a live minimum requirement of patient cases. So there are other states. We will look to those states, but we may take it even further beyond that. We want to, as I said, the board wants to do this safely, slowly, effectively, and do it right the first time. And we may become the model that other states then model after to do it right. The optometrists, yes, are still coming to the state. Part of that is because there are more optometrists that are coming out. As I had mentioned in my testimony last week, the rate of ophthalmologists is projected to continue declining. I believe somebody had asked in that hearing, and we did determine that it is projected that optometrists will grow by at least 9% over the next 10 years. So there will continue to be optometrists available. Our concern is that we want the best of the best to want to come here, to be practicing at that high level, and to be able to fully utilize the education that they have. Lastly, as far as the access issue, while these procedures may not be emergency, they may be elective. We don't want to wait until our patients are in a state of emergency to have to get these done. We had a case of a patient who, suffered terribly for quite six weeks when she had already been in her surgeon's office and was not treated at that day. And she had one eye. And while it was not an emergency, it was an elective procedure. So she can wait 6 weeks. And her life was miserable in those 6 weeks. So we want to be proactive and give patients access. There will still absolutely be cases of these same procedures that I could do that I will choose not to do in more complex cases where I'm going to recommend that they travel the distance to somebody who is going to be able to handle a higher risk case. That is part of our professional ethics and our training, and what we do is making those judgment calls. I think that covers what I wanted to respond to. Were there any other questions that you...
Any questions from subcommittee? Okay, thank you.
Thank you.
I'd like to, hang on a minute, we'll get back. Mr. Osterhout, if you can come up. And this is on page 8, starting at line 7. And the reason I'm asking him to come up and talk about this is this language was from OPLC at their request.
Mr. Chairman, when we have a hand raised,
Yeah,
but the thing is, if we get into something else, then she may
all right.
forget her question.
I mean, a brief response. I do not want to get an extended debate about all of this. So one person, a brief response to whatever's causing the hand raising. You need to come up.
I will keep this very, very brief, but in response to the particular case that was mentioned here of this woman needing to wait 6 weeks after she had already seen the surgeon, the primary reason that that happens is because we have to obtain prior authorization for the procedure. And if we truly want to improve access, there are other issues at hand that need to be addressed.
I understand. Unfortunately, that's the Commerce Committee and not us.
I just wanted to bring that to your
We
attention.
have enough to deal with.
That would
But
solve a
thank
lot
you,
of problems.
Thank you for that information.
Thank you.
Thank you. That's very important.
Yeah. That's all right. I don't need that. No. Anyway, if, this was, I added this at your request, so why don't you explain what this is about? I think I know, but, I'm sorry, page 8, it starts at line 7.
So this was just reading in the bill, I think a week ago. I just noticed some of the language conflicted with the procedures laid out in RSA 310. And so this proposal, very straightforward, is just to bring those in line with the OPLC statute.
Okay, if you could just mention some of them
Sure.
in general. Yeah.
Sure. So I'm on line 7, or I'm on line 9. Permits are now issued by the office pursuant to RSA 310-4, Roman numeral 2, parentheses C. Again, with line 13, the office issues that permit. Just going through. Line 22 on to 23. It says the business complies with all lawful directions and requirements for information from the Board of Pharmacy and the Board of Optometry of all states in which it conducts business. The only reason I added suggested language or other applicable licensing authority, where here's some states it's board, some states they're advisory. It's a catch-all language kind of thing. So whatever the licensing authority would be in the other state, that was my goal here. And I think that was it for my requests.
Okay, any questions? Representative Manchaputi.
Thank you, Mr. Chair. Thank you for taking my question. So the 21 to 23, that is in case of a reciprocity coming from another state, correct?
No. I don't think
For somebody, if I have had a optometry license
I
or
don't
board,
think
no?
it's got anything to do with that. You can address, but I think there's an earlier requirement in here related to that. So
Okay.
if you can,
One more follow-up.
well,
in
just
that-
explain what that's for, if you would. I mean,
Yeah,
well,
this is not related. So the reciprocity step would be in RSA 310-17 and then the PLC 313s. So this is related to, it doesn't really change the meaning of the chapter of 327-25.
let me,
for
so there is some restriction in
It's about
here
business.
on optometrists operating businesses retail businesses selling contact lenses. And it's related to that issue. It's, I mean, that part where that changes, okay, it says the office shall issue a permit to such out-of-state businesses, which I believe are businesses that are
Selling in the state.
in the state.
Correct.
And one of the requirements is the business complies with all lawful directions and requests for information from the Board of Pharmacy and the Board of Optometry or other applicable licensing authority of all states in which conducts business. So if they are asked to provide information from the licensing bodies in the other states where they operate, they have to provide it. But the issue is, that's not always called a board or whatever. So each state has their own language, and this allows for that.
So in regards to the clarification of that, so if I'm ordering my contacts or my glasses online after getting evaluation done by the optometrist or ophthalmologist here, that business that mails me, that this holds to those businesses that are not practicing here but are able to do commerce, e-commerce. And then I can go back to my optometrist or the ophthalmologist to clarify, yes, this is the right thing that came.
So, Doug,
Am I
think-
correct?
Well, Mike, I guess the question is, look at line 8, 7 and 8. For the sale at retail of contact lenses to individuals with the state, does that include ordering online, I guess is the question.
I've never looked at that question in detail, but my understanding would be if you're a business outside of the state shipping into the state, I would think the answer would be yes.
Okay. All right, thank
Yeah.
you.
Yeah, my kids order contacts and glasses. They get the evaluation done here and they would order online. It's much cheaper to get it that way. But they would go back to their eye doctor to make sure that's the right one.
Representative Brown.
Thank you, Mr. Chair. So OPLC permits businesses. That has nothing to do with the certification of optometrists and ophthalmologists.
In this section, correct.
Thank you.
Any other questions? Okay, thank you.
If I may,
Yes.
I reviewed the new language on page 7, and I've got some recommended changes
Okay.
there as well. I'll just go through them real quick. On line 7, there's a floating "and" towards the end of
Yeah,
that
I
sentence.
caught that. Thank you.
Grammar.
Grammar.
Section B, establishment of an application process under 310.4.2c. The process lies with the OPLC. So I would probably replace the words "an application process" with the word "criteria." Right, keeping in line with the board establishes the criteria, the office establishes the process. And I can give you my written
Yeah, if you could actually email it,
Sure.
that would be great. Any others?
sentence D, same statute, 310.4.2c, gives the office authority around the education. So I had stricken out development of protocols for proctoring and I had left criteria for requiring such proctoring. That sentence would obviously need to be tweaked. We'd have to probably define proctoring. I think that came up earlier in testimony. That needs to be more clearly defined. And then in E, implementation of an outcome reporting, I would change process to requirements because those would come in through the office. And then in section 2, I had stricken the words on line 24 to the Board of Optometry so that it reads, unless the optometrist has submitted evidence of satisfactory completion. And then I changed on line 25, board to office, because that information would come into us.
Okay, thank you. And if you could just send an email with those details.
Okay, I will do that.
Okay, thank you. Any other questions? Representative Manchaputi.
Sorry, after this, I'll be very quiet. It's hard. So with this the process, you're clearly dealing what is the process for OPLC, what is the process for the board, rulemaking requirement, professional requirement is set by the board, and OPLC just focuses on licensing and the process.
Correct.
Would this, in your mind, create a checks and balance to see what the OPLC has another shot at looking at what the applicant looks like?
I don't think we would be establishing criteria in any way, shape, or measure. We would use the criteria established by the board to make our determinations. And if it was a gray area or if there was a question, we would bring that question to the board. I think my changes here simply keep this bill in line with what we've done in 655, 409, et cetera.
All right, thank you. Representative Rhoda.
Yeah, I do want to make a comment though, because one of the things that we did with House Bill 655 was remove the subjectivity of applications of licenses, because what was happening was the board, when they were doing this, were interpreting the applicant depending on essay questions, and that brought bias and subjectivity into it. So by changing the criteria or making sure that it is objective, that was part of the reason why the office is doing this as opposed to the board. It separates them a little bit. So I wouldn't say it's a check and balance, but it's a more robust process and more fair.
And another way to look at it, which might help, is that what's in statute combined with what the boards create through rulemaking provides the rules of how licensing and complaints and everything else is supposed to be done. And the office basically just is the machinery that carries it out based on those rules. But they're not making policy decisions because that's in either statute or rules.
That would give the legislative body to hold the process or the indirectly through OPLC and through the board, that we have the oversight responsibility.
Right. We're giving the board the authority to where they can do rulemaking, and then once that process is done, it's OPLC's job to carry it out. So, anyone else for this section? Not for this section. Okay, thank you. The next section is actually at the bottom of page 7, the same page, and going into the next page. And this is, or is this the one I'd already covered? Right, that's the one I look at. Sorry, next page, page 8, starting at line, no, we already did that. I'm off the right page. Okay, at the bottom of page 8, towards the bottom, I'm getting there. In line 34, this is regard to the requirements for continuing education, in addition to those set by RSA 327.33. And what this and what's on the next page, including line 6, is some sort of rework to that. So right now, there's I've got it here. Yeah, I've got I'm looking actually at the statute. Right now, the continuing education is broken up into pharmaceutical versus non-pharmaceutical, and then also glaucoma or non-glaucoma. And it gets into how that continuing education should be split up. And I think the general idea is that should really be handled through rulemaking. I mean, the statute sets the overall outline of that there needs to be some continuing education, but the details on it really shouldn't be in statute. So what this all does is it repeals 33A, which is continuing education is required for pharmaceutical and glaucoma certification, and it changes 32733 to just say continuing education courses required. An optometrist shall complete a minimum of 20 hours of continuing education by participation in formal synchronous courses each year in order to maintain active licenses. And there is, I believe, in 32731, that's on rulemaking. Let's see. I think there's something there, or elsewhere. Actually, Roman 5 requirements for continuing education. In addition to those requirements set by RSA 32733. Oh, and this needs to be. Well, I got rid of the reference to 33A in the repeal. So basically, through rulemaking, the board would set what are the requirements. This sets the overall amount, but what are the requirements? What courses will meet the requirements and that sort of thing. So any questions on that? Okay. Representative Grota?
Yeah, so I'm just trying to figure out. So, because we're amending different statutes, it's all kind of intermingled.
Right. OLS may change the
I was
order
going to say,
and
I
create
think
sections.
OLS may change this
Yeah.
to be more logical.
Yeah, I was editing what was in place and, right. But yeah, whether it's separate sections and in whatever order is.
So my question to you and maybe to members here, has the continuing education courses for 20 hours, has that been current practice?
Yeah. Well, actually, it was you can come up here, but I'll say something first and ask you to answer that. Yeah, it's a little. Actually, why don't you just answer it?
So previously, there were separate classifications, and there was a group of optometrists that were not prescribing medications that only needed 15 hours. We're now simplifying that. Everybody will need the 20 hours. The 20 hours of live formal courses is what it has been all along. Again, the SB 440 did eliminate from statute. The board may still, in rulemaking, add other things, but there was an additional 30 hours of strictly independent study that was really not trackable. And so that was removed from statute, but the statute will remain that it is 20 hours, and it is increasing from 15 to 20 so that it's 20 for everybody.
Okay, and if it's 20 for everybody, follow up? Sorry.
Follow up. Yep.
If it's 20 for everybody, for these people who might be certified to do the new procedure, wouldn't there still be
It may
additional?
supersede. Yes, it may supersede that. The 20 is the minimum for everybody,
Yes.
and then the board can add additional. The board may specify when they're doing these, the rulemaking for these procedures, that some of that 20 might need to be in specific things, or they may need something beyond that 20 to be able to maintain.
Okay. So I'd like to beef that up a little bit on and I'll try to come up with some language, because the minimum of 20 hours just basically says that. So we could put additional hours required for.
So it does specify that within the new section that is being added, 327.6D, that the board there would establish minimum education for those procedures. So
okay.
it
I'm
does
sorry.
allow them there.
Where is that?
That's within our new section 11. I'm sorry, I don't have your
I'll
current
have it
draft
there
of
in a
two
moment.
page number.
I've got the page.
Page 7, line 16.
327.
Oh, okay, got it.
6D1 and then the sub list.
all right.
It does specifically
As well,
indicate that they
okay.
will have education requirements specifically for these procedures.
Right.
So that general 20 hours of education is for everybody across the board, but then may be supplemented in rulemaking.
Okay, I understand. Yep. Okay, got it. Thank you so much.
Thank
Very
you.
helpful.
Okay, so that actually, we've gone through all of the proposed changes to the bill. So any other discussion on this?
So one comment that I had, are you asking? I just jump in and take? I won't even raise my hand. I'm so sorry. Is that in the original bill? It had what the bill did not allow, and am I?
Oh,
And I would rather have it say what it allows.
I think it has both.
Okay, it could.
Page 3, starting on line 6,
Yeah.
it's got the practice of optometry, and it lists the, Part A lists the things that they may do, and Part B lists the things that they may not do. And,
may I follow up on that?
Go jump in.
all right, Representative, he had asked earlier. Representative Brown?
Sorry, go ahead.
No, go ahead. Yeah.
Thank you, Mr. Chair. So that's a question that I had based on the 44 items in the back of one of your books that optometrists were looking to do, or the 220 codes that ophthalmologists can do. Is the way this is written now, and again, we're all seeing this first time this morning.
Well, not this part. This is existing bill.
No, I understand that. So the way that your amendment comes out with the exemptions, there's only a certain number of exemptions. Does that still mean that optometrists can do everything else if the board, or is it only if the board says they can?
Well, first of all, it's for them to do anything, it's got to be covered in Part A, starting at line 7.
Right.
Now, those are general. And by the way, the amendment I proposed does not change this section whatsoever. That's in the original bill. Okay.
And I guess so yes, following up,
Yeah,
sir, sorry.
certainly.
That's one of my concerns. We have to be clear on what is allowed and what isn't allowed, I guess, before the board gets to it. Because if this passes, as whichever version, if it passes, what is allowed or exempt is irrelevant to future rulemaking. Would that be accurate?
No, actually, if you can come first, and we'll get a response. Again, introduce yourself again.
Yes, again,
briefly.
I'm Dr. Angelique Sawyer, North Conway and in
Hang
Berlin.
on, just a moment. Reverend Simon had a comment?
Yeah, if I could ask this just so that you can
Please.
cover it when you're answering the question, because I think it'll kind of go in the same vein. My main concern with this section was whether or not there was going to be something that we're not considering at the moment, something that comes along in the future that isn't exempted, it isn't in this list, and what happens with that when it comes up. So is it going to be open for optometrists to do that procedure simply because it's not in the exclusion list? Is that a possibility?
So the intention, and hopefully this clarifies, so the list of exclusions, the board cannot go beyond that. So if something came along that was, for example, a retinal procedure, a retinal surgery, that would still not be something that optometry would be able to do. The new section that is being added, the 327.6D, of those bullet points, the first one is identification and categorization of the ophthalmic procedures for the practice of optometry. And so that is where the board would specifically name those procedures. And so if something came along, then an optometrist or someone would bring to the board, is this something that we're able to do? And it would go through rulemaking to determine if that can be included in the list that they're creating or whether it is outside. And the language in Part 1 there says that it must be consistent with curriculum of nationally accredited schools and colleges of optometry. So if it is not something that is being taught in an accredited school, it is not something the board would be able to do.
Excuse me, where were you?
Sorry, that is all within 327.6D. It was section 11 of the bill. I don't have line numbers.
I think it's on 7, no, it's, nope, wrong copy. That's the original bill, so of course I'm not going to find it.
11.
But what she's referring to is on page 7.
Page 7, section.
Yeah.
Yes. So one, the board is held only to what is taught in the accredited schools and colleges of optometry. So if something new comes along that is not being taught, that is not something the board can allow. The board in sub-item A there has identification and categorization of the procedures for the practice of optometry. And so that is where the specific procedures would be named rather than naming in statute and having to come back and change statute. If a procedure had a change in name or a sub-procedure was developed, the board would be able to address through rulemaking.
Representative Simon, you had.
Thank you. Yes, and I understand the process, and thank you for the clarification. I guess my question is more, and for both sides actually, is the list exhaustive? Does everybody see it as exhaustive, or is there something that we might be missing that might pop up in the future? That's my concern, that isn't covered by any of the things that you've said, any of the caveats, any of the protections, something that could fall outside the realm of that, because our job is to close those things up before it gets to the board. I'm happy to let the board do the board's thing,
Yep.
but we need to make sure that we've done our due diligence on the front side. So, Mr. Chair, if anybody is able to mention something that they don't think is exhaustively covered in the list, so we could talk about that,
In
that would
other
be helpful
words,
to me.
This is the list of things that are not permitted.
Right.
That's something that should be added that is not in there.
Right. Something that should be added to the. You can't
Yes.
do this list.
Yes, we are open to adding more exclusions if there's things that anyone feels have been left off the table that need to be included there.
And before we go on to anyone else, Representative Broda, did you have a question?
Okay, because this is what, so I'm looking at page 3 of the thing that everybody is looking at right now, which has not changed from the original bill, which starts with, okay, at the top, section 4, practice of optometry. So all of these things, are these things like 1, 2, 3, 4, and 5, are these things changing as a result of this bill, or are these the things that you've always done?
Those, in Part A, items 1, 2, 3, 4, and 5 are things that we've always done.
Okay.
The only change other than, because the B was added, they had an A and then changed the headings.
Yes, I understand that.
The other change is removal of the words other than surgery in A. Which
is a
kind
big
of
change.
Required for the, if we're going to do
Which is
this.
why the new section.
Yes, okay. But then in B, and then we struck out F, which
Yes.
was the acute angle closure of glaucoma, which we heard as many times at the hearing. I still don't know what that is, but you're saying that you are not going to diagnose that.
We can diagnose that. So it specifically in the past said that when it was diagnosed, it then required immediate referral to an ophthalmologist. If the procedures are permitted and the optometrist can perform that laser surgery, then that referral to an ophthalmologist immediately in that moment, it would either go to an ophthalmologist or somebody who's able to perform that procedure.
Okay. Go ahead.
Representative Brown.
Excuse me, I'm
Yeah,
sorry.
yeah, Representative Brown.
I'm kind of talking to myself, I guess. So that strikeout on line 19 through 21
Yes.
of the diagnosis, then your ability to do that falls back to number 1?
Yes.
That would be included in number 1?
Yes, exactly. Thank you.
Okay. Oh, I'm not finished with my. He just
sorry,
jumped in.
sorry.
That's okay. That's all right. I was just pausing.
No,
No?
don't.
I think you're a member of this committee, and I am not. I'm an interloper.
Representative Brown.
And then from line 22, it shall not mean the following, and it lists all these things that you cannot do, and it goes all the way to the next page.
Yes.
Right. So, is there anything else on this list? That's the point that we're trying to get to. Is there anything on this list that you would not be able to do based on your training? Whether it's
There
under the criteria that we just established.
Yep. There may be things that are outside of our training that our board would not authorize to do that are not necessarily excluded here. And if that is the case, it's an oversight. Our attempt is to exclude things that are not within our training.
Right.
But because training is continually advancing, the board would limit to only things that are within the training and that are not excluded by here. And to my knowledge, there are not other procedures out there that we are aiming to do that are not being addressed by this, or that the board is not planning to list out in rulemaking.
Last question.
Representative Grota.
Thank you. So, according to this, any procedure that requires general anesthesia, you were not allowed to give general anesthesia.
No.
Good. Okay. And then follow up?
Correct. That is correct.
Follow up?
Correct. We are not able to.
But you are, do they give, I don't know, like topical anesthesia to the eye?
Topical anesthesia, yes.
And would you be trained for that?
Yes.
Okay. I think that's it for right now. But I still would like to have a list of things that they can do, because you're saying that it's three lasers, something to do with a map.
We can we can share with you what the board has drafted so far, where that list is
I just got that from.
is forming.
Okay, because I think that it's rather YAG, not map, YAG.
That's okay.
So because there are surgeries, so let's just use the example of the three lasers, right? How many? I have no idea how many lasers are there. Can the laser that's used to do something that you can do, can it be used for something that you can't do? Or are these lasers process specific, procedure specific?
Right. There may be now, and there may be development of other uses for the lasers, but we're not permitted to just freely use a laser. We are permitted for a specific procedure by the board, where they're naming out this YAG capsulotomy procedure is what you would be able to do. And if that laser develops a new purpose or a new use, they would only be able to do it once authorized by the board. Once the board has included that in the list of procedures that fall under the certification.
Which will go through rulemaking.
See, this is the part that concerns me, because if, for example, I'm going to go back to the splinter, all right? Let's say, even though it's a terrible analogy, but I can't think of anything else. Let's say the laser can remove the splinter. But then let's say the laser can fix the tendon in my finger, the same laser. So the person that owns the laser can use it to take the splinter out. But then at what point does optometry and its training enter a realm of ophthalmology and their training? And at what point, because obviously ophthalmologists study the eye as well, and they have specific specialties, and they're trained for those, and you're trained for yours. And I'm going to, even though it's an awful analogy,
okay.
I'm also going to use a
So-
ladder. So, you know, you're
Right.
you're stepping up the ladder. And are we at the point, is this bill, and it sounds to me that this does, is that it overlaps some of the responsibilities of the ophthalmologist and the optometrist in those sections of procedures that are less risky than others. Obviously, if your retina is detached, that's a big deal, and you got to go, right? But does that mean that the width of that band would grow with time? I guess that's something that we have to. You're looking at me like, no, I'm looking at Tony.
No. I'm trying to understand where
I'm
you're going.
trying. I guess my concern is
No,
that
it's a good investigation.
I just want to make sure that I'm going to call it capability creep.
So Right.
doesn't go beyond your capability, and how do we safeguard
Absolutely. So in your example with the splinter and then the laser could do something more, there are procedure codes. Removal of that splinter is one procedure. Repair of the tissue or going down into the tendon or doing something different is another procedure.
that? Okay, that makes
And
sense.
so through procedure codes is where the board would be identifying these are the things that are approved through
And
that part A of the identification of procedures.
Okay, any other but I saw hands, and when we're done with questions for this person, I'll let somebody else on the other side respond, or comment. He had asked Representative Brown and then Representative Montepudi, or Gould and then Montepudi.
Yep, thank you, Mr. Chair. So for everyone, my concern about this is that I don't understand how, well, let's use a simple example. In a residency for an ophthalmologist, how many times have you used a scalpel on a live person to practice a procedure? And for an optometrist that wants to do that same procedure that has never had that amount of training, how can you guarantee to me that you will get that before you do that procedure? I don't even know what the numbers are.
So I believe we have the ACGME chart of the procedures and the number of codes. If we have not provided that, we can get that. They have a long list of requirements, and we've highlighted the only 4 procedures on that list that we would be anticipating doing the rest are excluded by the list of exclusions. And
Okay, and to follow up,
Let me try a more general answer, and then
Okay,
you can
okay, yep, yep.
ask anything that falls on it. So the section on page 7, it says that, that they're not allowed to do any procedure unless they, the board is has rulemaking, they're required to do rulemaking to categorize the ophthalmic procedures into presumably groups. So they're not dealing with every one of these things.
Yep.
And then they will establish criteria for certification to perform those procedures and establish a minimum education, training, and live experience requirements for certification to perform such procedures.
I guess that's my question.
And that's rulemaking. And if they perform the procedure without that certification, that's a disciplinary offense. I mean,
That's too late.
well,
Sorry, but that's too late for the patient.
I mean, you can't, what you're saying is anyone can break the law, and we can't, how do you prevent someone from breaking the law ahead of time in any realm? All you can do is provide deterrence and deal with the case where it happens. At least that's my take. Representative Grota? Yeah.
I just want to make a comment about this because I do believe that people in the healthcare industry care about people.
Yeah.
And they're not going to, just like I would not remove a splinter from, my finger because I would not feel qualified to do that. Most people, if they have any humanity at all, are going to care about a procedure on someone's eye on whether or not they're qualified. I mean, my goodness, do we have such a low opinion of our own professions and our own individuality that we would think something like that? I hope not.
And actually, a question related to that is, I think you mentioned before, but I believe the training for optometrists, and I'm sure for ophthalmologists, includes some training on the issue of ethics. Is that not correct?
100%, yes. And we take an oath we take an optometric oath to care for our patients, and that includes ethics within the oath.
Representative Gould, yep.
Thank you, Mr. Chair, and thank you for taking my question. So what I'm trying to get my head around is the lists of prohibited and the lists of permitted, and particularly, first of all, let me say what I love about this process is I think it's been an incredible educational process for everybody about how these systems work. and what our role is and what everybody else's role, what the boards do, rulemaking, all of that, both for some people in the audience and for some of the newer committee members. But what I'm struggling with here is if we want to make our statutes set up in a way that allows the board to exercise the kind of professionalism that I think Representative Grota just laid out, ethics, integrity, professionalism, and not bind our boards to having to come back to this body and us to have to listen to and educate the next reiteration of fearful public and professionals. Why do we have to have these exact lists in here? Is this because there's turf or fear things going on that we're having to protect the obstacles that have been discussed? I'm trying to understand why these specific items need to be in this bill.
Why the exclusions need to be there?
Yeah, and also the permissibles.
So the exclusions are there for reassurance. I believe that if these exclusions were not here in the statute, the board would still implement these exclusions because these are not within our education and training. But at this point, we wanted to leave in statute where those who have concerns about this can see that there are still parameters that the board has to operate within, including things that we know are not in the education and training of any optometrist at this point. So those are being excluded. And then giving the board the authority outside of those exclusions to, within education and training and within a very thorough rulemaking procedure, to prove the education, to prove that it's being taught in accredited schools, to prove that there is live experience. And if there's a procedure that we can't get live experience, then that's a procedure that we may not be doing, that the board may not be able to authorize. So
Thank you. And follow up. So I like the idea of the more general, I guess is the right way to say it, the more or procedural coverage if it's trained by an accredited school. What I'm concerned about is on the exclusion list, and I trust you, you know this. I don't want to know this. I don't want to become an expert in your field. Are you really certain that this list of exclusions is not something that is going to, we've talked about the training, the educational facilities are going to be upping their game as we're breaking new ground in allowing more procedures to be done by you all. Are you confident that these should be on that list?
I am confident that at this point and for the foreseeable near future for what is being taught in schools at this point, that these exclusions are not going to create more barriers.
Thank you. And for as a Native American, the next 7 generations are what we look at. So thank you.
Thank you.
You still have a question? Representative Mangiapudi.
Thank you, Mr. Chair. Thank you for taking my question again. I will go to page 3, line 22. It says, shall not mean the following ophthalmic surgery procedures except for the preoperative and post-operative care, which means there is a collaborative effort to work with the ophthalmologist. And does that still work in the, it's a team effort, right? Super specialty should not become more siloed. And so would this ensure that the optometries and the ophthalmology can still coexist and work collaboratively for a better outcome and safety for all who need the care? I can only address it for the Granite State.
I certainly hope so. I have very valuable, trusted relationships with providers that I refer to and that I'm going to need to continue to refer to. And I want all of them to know that that trust will continue to be there. There may be some of these procedures that are excluded that we don't provide even the pre and post operative care of because that's beyond our expertise and that they are best in those risky, complicated situations, staying with that surgeon for even the pre and post operative care. But this does leave it open for when there is the mutual relationship there and the optometrist can provide pre and post operative care at the surgeon's discretion. We want that to continue and we hope that that will continue on both sides.
You have, Reverend Schmidt?
I read that language very carefully. And it's just perfectly obvious that if you are an eye person, okay, and you look at the person's eye and you say, wow, you're going to need something more that I can't do. That's preoperative. You're going like, holy hell, get Dr. X on the line, okay? And once you've had the procedure, then you're looking at their eye about something completely different later. That's all post-operative. I mean, it's just as obvious as, don't dive off the pool until the diving board without checking for water in the pool.
So let me kind of expand on that and actually ask a question. And that is, are there some procedures that ophthalmologists do today where they work with optometrists to do at least some part of the preoperative and postoperative care that's planned, that's not if a problem is found?
Yes, cataract surgery is the most common, particularly in my area. My surgeons are an hour away from the Berlin office. So if you need cataract surgery, you are traveling. When it is a straightforward case that the surgeon is comfortable with me taking over the postoperative care, they do not need to go back to their surgeon for their follow-ups. And so that is a very common practice throughout the state, both pre and postoperatively.
Okay, thank you. Any other questions for Dr. Sawyer? All right. Oh, wait, Representative Grota.
Thank you. So going to the part where it says where preoperative and postoperative care of, and it says retina laser procedures, penetrating keratoplasty or cornea, all those F, from A to F. Do you assist now on these?
For some of them, yes, not all of them.
Sorry.
Most commonly, we do pre and post operative care for refractive surgery. We do pre and post operative care if somebody has had a corneal transplant. Usually, they're going to stay pretty close to their surgeon for a while, but there does come a point where they are transferred back to their optometrist. Usually, if it's a procedure that has required general anesthesia, the majority of that follow-up care, that post-operative care, is likely going to be held close to the surgeon. So, but some of these, yes.
Follow?
And I don't see cataract surgery here. Is that
Under the subsection, the part 2, the following non-laser surgeries, the line F is extraction of the crystalline lens, and G is surgical intraocular implants.
okay? Got it. Thank you.
Any other questions for Dr. Sawyer? Okay, thank you. And if one person, some ophthalmologist would like to comment on this section. Yes, I do. The blue book, so that's this thing, yeah. And yeah, please introduce yourself.
Hi, my name is Anthony Correnti. I'm an ophthalmologist at New Hampshire Eye Associates in Manchester. Thank you for giving me the opportunity to speak today. So a couple of things. On the exclusionary list, I know it's a confusing part of the language in the bill, and we found it equally confusing. Initially, our panel had looked at that exclusionary list and identified over 250 ophthalmic procedures that would be permissible under the statute. We spoke with the optometrist, and they provide us a list of 44, which is in the very back section of your blue book. It's in the yellow. It's highlighted in yellow. So the green part is what they can do now. It's the very back.
Page 36.
36. Anybody else need one? We're good? So if there's any question about what they're asking to do, no, we were tasked with my speaker packet to look at each one of these and decide if there was anything we could permit optometrists to perform. In your senior,
I'd like to correct your language. You're not in a position to permit or not permit anything.
okay, my apologies.
Yeah.
He asked us to look at the procedure list and comment. In that list, we identified four. Identified four procedures that we identified as safe and minor. With regards to the exclusionary list, though, I do want to get back to it because it is an interesting topic, and we were looking at other organizations or other governing boards in New Hampshire, including podiatry and dentistry. And when you look at their governing board, you look at their scope of practice, they are defined as inclusionary. So, for example, podiatry, if you look at their inclusionary language, and I won't go through the whole statute, but it defines it as surgical means and ailments of the human foot and lower leg. So the analogy here and the concern we have is that you're almost saying, like a podiatrist, well, you can't do the head, you can't do the chest, you can't do the abdomen. Well, does that mean you can do the hip? Does that mean you can do the knee? It's a confusing part. So in our world, this is saying the same thing here, that there's so many unknowns as to how many procedures will be allowed by Senate Bill 440. Excuse me, that's number one. I wanted to go back, if we could, to the first of all, I appreciate your folks putting the time into this. We've only seen this new amendment for about an hour and a half, so we're kind of going through it here, and I apologize if I misspeak. But the exoskeleton that was discussed, there was a mention of the ACGME requirements that were utilized, I guess, as part of that. I do want to mention about the ACGME in their statute or in their rules. They do define minimum numbers represent what the review committee believes to be an acceptable minimal experience. Minimum numbers are not a final target number, and achievement does not signify competence. So in other words, the ACGME accredits these residency programs with a minimum standard, but it's actually up to the residency program director to determine competency. With regards to surgical residency programs in optometry, we're still a bit confused by this. I know they have residency programs, but to say that there's a equivalent to an ophthalmology residency program where they're accredited, where they're licensed, accredited, mentored, and have a minimum case number, we have not seen that to exist, and we don't feel that equating the quote unquote residency programs that exist now are similar to the surgical residency programs that we go through in terms of accreditation, in terms of minimal surgical volume, and. Yeah. Lastly, I have to look at the exoskeleton details more closely, but I think it'd be very hard to recreate the residency experience with anything that wasn't mentored, that wasn't supervised, that didn't have live patient experience. And I haven't looked at the details, but I look forward to hearing more about it, certainly. And that's all I wanted to say today.
All right. All I'd say is that the new 327-6D, it requires live experience, and it requires that they're going to be. It says proctoring. The language may change, but basically, or we need to talk about that. But they're not just going to be having these live experiences on their own without somebody watching what they're doing and directing what they're doing. So that's in there, and the board is charged with rulemaking for the details of all of these. So that before any optometrist can do any of this, that has to be completed. And I suspect, I'm not that familiar with the Board of Medicine statutes that are directly related to ophthalmologists, but correct me if I'm wrong, but are the details of criteria for ophthalmologists doing any particular procedure laid out in statute?
No, they're not.
Right. And I don't even know if they're laid out in rules.
Our competency comes from the residency experience and having essentially passing the test of 3 years of residency. That's where our
I
certification.
understand. I think because at least at this point with optometrists, and if I'm misstating something, let me know, that isn't fully developed because it couldn't be, because many states would not permit it. The requirement is that the board, and again, everybody will have input on this rulemaking. The board is directed to provide rulemaking on this, and, as they've expressed it, they'll presumably be guided by, the optometrist certification organization now, and also for the other procedures by the one for the ophthalmologists, and then, and that's just, and set the minimums for that. So anyway, it's not, there's more to it, I think, than you seem to be indicating in what you're saying. That's my only point on that. Representative Grota, Brown, and Mangiapudi, unless there's somebody else.
So in this book, some of these proposed codes are in yellow and some are in green. Why is that?
The green is what they are by statute allowed to do now, and the yellow is what they are asking.
Right, and when you negotiate, this whole one of the reasons why there was supposed to be a negotiation between. So, what of these yellow ones did you concede that would be okay?
If you go to the introduction section, so if you go to page, it is page 4 of the booklet.
Yeah.
The 4 CPT code listed at the top of that booklet.
So 4
Yes.
out of the 44.
Yeah. We convened a panel of oculoplastics, cornea, and glaucoma specialists to review that thoroughly.
Okay, thank you.
Okay, any other questions? Actually, there were some others. Representative Brown?
Okay, thank you, Mr. Chair. So you may not be able to answer this, but maybe someone else can. As you go through a surgical residency, obviously you have X amount of hours and you do all this work. If an optometrist, for example, didn't get the amount of practice for particular surgical techniques, how is that going to happen afterwards? You're out of school, you're now an optometrist. How do you get that hands-on, where do you go to get that hands-on live patient work?
I think that could most appropriately be answered by Dr. Sawyer or someone on that side, because, yeah.
Yes, I mean to answer that, we're not aware of any accredited surgical residencies in optometry and as Dr. Cottle had mentioned, that there is no minimum, quote unquote, minimum at the testimony. He mentioned there's no minimum either, but we're not aware of any accredited that you can equate to a ophthalmology surgical residency that exists.
Yeah, we'll get someone else up to.
No, I understand. I understand that for sure. Thank you.
Someone else? Representative Mangiapudi.
Thank you, Mr. Chair. Thank you for taking my question. Again, I'll go back to the section where it says, shall not mean the following ophthalmic surgery procedures except for the preoperative, postoperative. So currently, there are many practices, many hospitals, and private practices like Nashua Associates. There are 10 optometrists, 14 ophthalmologists with all specialty working together, right?
Yes, including my practice.
Yes. So do you see any obstacle? Because for me, it's important that we don't create more silos. Saying, I'm left thumb specialist, so I don't, I only do this. The super specialties started with the intention of working as a team. So I am seeing some, or is it my own perception that I'm seeing that this is my territory, this is your territory, that territorial thing where the patient is going to be compromised, not getting the much needed care at this time. Do you see anything like that with this, if this bill passes with all the amendments, with all the inclusions?
I go back to the exoskeleton was mentioned. I go back to what we know is the standard in ophthalmology is the certified residency experience, 17,000 hours mentored with minimum standards and display of competency. And I would be lying to you if I didn't say if there was a pathway. We just I don't see a similar model set up that would allow that level of training in the current system.
Follow up with that, just that one?
Follow up.
Yeah, so this is, it says it's not doing this surgery, it's pre and post care. They might not even, optometrists may not even do the pre and post care. Is there room for that collaboration to say, you know, optometrist can bring it up to this level with the current education, with the current technological advancements in the field of ophthalmic procedures? Just if I take just the contacts,
Yeah, I'd
it
like to-
used to be that hard glass you have to take, clean it. Now you can wear it for 30 days.
Yeah, and,
Right?
and the relationship has always been very collaborative. I don't discount that. I mean, the optometrists in our practice see manage medical diseases. They medically manage glaucoma, and it's extremely collaborative. I think the analogy earlier was that ladder that we're talking about. It's like how far up the ladder, and we've said before that when the surgical when you're talking about lasers and surgery and potentially blinding procedures here where the margin of error is so small, it really requires a level of experience and surgical training that again we do in residency.
All right. At this point, I think we're going to take a short caucus. The Representative Brown and Bailey, we're going to go in the office there, and Representative Grota, where you want to go. So we'll be back. I don't expect, hopefully not more than 10 minutes or so. Okay, on Senate Bill 440, and I'm going to make a motion, which is that we accept the amended language that I sent out. Have to have an actual official amendment drafted by OLS for before next Wednesday, and with the technical language changes that were requested by OPLC for the section 327-6D, just to make clear what's the responsibility of the board versus the office. And there may be some technical changes, the exact descriptions of some items on the exclusionary list, and those would be in there as well. But that's what the motion is. Do I have a second? Okay.
Clarification, Mr. Chair.
Yeah.
So
Well, actually,
you're making a motion for an amendment
Right.
that will have all the changes that we discussed as an amendment,
Correct.
not as an amended bill that
no,
we
no,
have right now.
we can't. We can't do that. All right, I'm just making some notes here. And then, all right, so, and this is just the members, official members of the subcommittee to vote. All who are in favor? Or, well, actually, we can have some discussion if you like. Sorry. Any discussion?
Yes, thank you, Mr. Chair. So we talked about this, obviously, in the back room. I'm,
Oh, we can't talk about what happened in Prague?
no, it's a secret. I'm not
The
telling you.
rules. Rules is rules. Yeah.
I'm going to vote for this with the understanding from Representative Simon's back of the room conversations and the way I believe the bill reads after having a conversation, that the live experience requirements that will come through rulemaking, however that works, however you're going to get your live experience, will protect public safety by not allowing anyone to do these procedures. That's not qualified. Thank you, Mr. Chair.
Right, and I think that's pretty clear in statute. If they're told they can't do it, and if they do, there's disciplinary action. So I think that will assure that. Any other discussion? Representative Mangiapudi.
I will support the amended version with the understanding that the collaborative effort between the ophthalmologist and the optometrist will enhance, not create more isolation. So the collaborative effort that would benefit the Granite Staters to get the best possible care at the best, most as quickly as possible and as reasonably as possible. So that's with that intention, with that understanding, I will support this.
Thank you. I share the same expectations. Anyone else? Okay. All in. Yep.
Do I get to say something even though I don't have?
I think
Okay.
at this point, I'd like to lunchtime. All in favor? Aye. Anyone opposed? Okay. The next motion, I need a motion for OTPA, which I can make or someone else can. Okay. OTPA ought to pass with the amendment, and that's Representative Gould and Brown. Representative Gould, would you like to speak to your motion?
I think we've said everything we need to say.
Representative Brown.
I agree with that.
Okay. All in favor? Oh, discussion. Okay.
Sorry. So this will come to our full committee next week. So we'll have the amendment and with the vote.
Right.
And we'll have to.
I will add the minor changes we discussed. I will send this off to OLS, get an amendment. I'll take a quick look to make sure they did it correctly, and then I'll send it out to the full committee
Thank you.
as soon as I get it. Any other discussion? Okay. All in favor? Anyone opposed? Okay, I'm going to close the subcommittee work session on Senate Bill 440. Thank you, everyone, both on this side and that side.
Fishing game is much easier.
What's that?
Fishing games are much easier.